familiar with the National Health and Nutrition Examination Survey? Besides hearing of it, okay. So this will be new for most of you. That's great. Then I'm going to give you some examples of the population data from NHANES. And I've selected some personal care products, some lifestyle behavior choices, specifically secondhand smoke, and then a little bit on some food contamination issues, which one of my dear friends who is an OBGYN said, oh, you've got to talk to him about mercury and arsenic and all. And I said, okay. And then briefly touch on the National Children's Study. And it's had its challenges, but it still holds some promise, I think, to fill some data gaps that we have in the NHANES survey. So all of you are very familiar with the fact that we are exposed to all sorts of environmental chemicals, to the air we breathe, the water we drink, the food we eat, and the products we use. And for women in particular, cosmetics have been a source of concern. Now, to evaluate or to assess exposures to these various environmental sources of exposure, we have some different approaches that can be used. Now, questionnaires, historical information, including GIS and video, as you've heard described today. I think Dr. Pereira talked about how they use GIS to capture information about personal exposures. So that's kind of one approach. Environmental monitoring is another approach. You can measure environmental contaminants in the air, in the water, and in the food. And those are typically purviews of the Food and Drug Administration with regard to contaminants in food, and for the EPA, environmental contaminants, and they do quite a job of monitoring particularly air and to some extent soil and water. Personal monitoring, I think in the last 10 to 15 years, personal monitoring has really taken off. I went to a conference and they were talking about the use of various smartphone apps and combinations of some sampling devices tied in with smartphones that could transmit the data. I mean, it's really exciting. So the potential to get better information about even moment-to-moment or continuous exposure around the personal, like the backpack that you saw was one technique, but they're getting even more sophisticated, and it's getting to be less intrusive, which is one of the limitations of a lot of personal monitoring. For those of you who are in the clinical settings, you're probably familiar with the radiation badges, which are another type of personal monitoring. So that's kind of what we're talking about. And then the fourth of these methods of assessing exposure is biomonitoring, or biological monitoring, which may be an unfamiliar term, but I think as I get into talking about it, you're going to say, oh yeah, I know what that is. Now, many approaches to assessing exposures combine various mixtures or combinations of these techniques, but I'm going to be sticking with really the biomonitoring. Now, at CDC, we have defined biomonitoring as you see here, as the assessment of an internal dose by measuring the parent chemical or a metabolite or a reaction product in human specimens. Now, the key points about biomonitoring is that it integrates all sources and routes of exposure. So, for example, blood lead was talked about quite a bit today. You can measure lead in blood. That lead may have gotten into the blood by a variety of routes of exposures and by a variety of sources in the environment. So, biomonitoring is not a technique that's going to help you figure out precisely where that contamination source was or how it even got into a person, because lead, you can inhale it in dust, you can ingest it, there are multiple, and obviously you heard a lot about sources of the lead in the environment that can get into people. The other aspect I really want to highlight, and I'm not going to go heavily into the laboratory side of this, but being a clinician and coming to the Division of Laboratory Science, I have gained a tremendous appreciation for the complexities, intricacies, and the importance of really understanding. We're measuring, in most biomonitoring measurements, we are measuring trace concentrations. And what that means is we're measuring right down at the limit of our ability to detect these concentrations. And that has a tremendous implications for interpreting the data and for the data in populations, because if you have a large percentage of the population in whom we cannot detect it, does that mean it's not there? No, it means it's below the limit of detection. And I'll allude to a little bit of this with the complexity that we have sort of created by desiring to measure lower and lower blood lead concentrations. Because at this point in time, the ability to measure blood lead is right around the threshold of where we want to see the value, or not see the value above that. And it has implications for how you can interpret changes at these very low levels in the blood or in the matrix that you're measuring in. And then I just want to point out, to remind you that we're measuring concentrations of chemicals in biological samples, typically urine and blood. We're not necessarily measuring the exposure per se. And when we measure metabolite, we may be measuring an active or an inactive chemical. So it really may just be passing through the body at that point. So sometimes you have to know something about the pharmacology or the toxicology of the chemical to be able to interpret the results. I may refer to these biomonitoring measurements as exposure biomarkers. We kind of use those terms interchangeably. So there are other kinds of biomarkers. There are biomarkers of effect, but I'm talking exclusively about biomarkers of exposure. So just to set the stage. So as I mentioned, there are, in biomonitoring, we typically are involved in some large-scale surveys. And these are population-based, the ones I'm going to talk about, particularly in Haynes, the National Health and Nutrition Examination, and the National Children's Study, which I will allude to because it's still a work in progress, as it has been for quite a while, and it's not clear exactly what kind of population they're going to be sampling at this point. So I can't say without reservation that it's going to be population-based. The other thing I will mention, because you probably read all the time various epidemiologic studies of specific populations. Dr. Pereira talked about a cohort that they have assembled. It's a very clearly defined but specific population, and they do a number of different studies in those to try and determine the linkage between exposures and a variety of outcomes. And in those settings, a lot of additional information, which you described, the information about maternal history, socioeconomic information, lots of interview data, nutritional data. They try to gather really a whole body of information, and that's what is needed in an epidemiologic study to try to make any linkages between exposures and outcomes. So our large-scale population survey that I'm going to talk to you about, NHANES and at this point the NCS with what we have today, can't really provide that, but what it can provide, and the NHANES does provide, is very important reference values, so that there is a value, or you have for a general population reference values. And what do you need a reference value for? Well, what are you going to compare any other values to? You got to have something to use for comparison purposes. So since NHANES is not familiar to all of you, and I do want to give you a little bit of background, because I think this is one of the possibly less recognized, but really an invaluable resource in public health and, by extension, in clinical medicine. The survey, as it was conceived as the National Health and Nutrition Survey, was begun in 1971, but actually the genesis goes back to the 1950s, when there was a recognition that there were certain deficiency states, nutritional deficiency states in subsets of the population, and some congressional, and there was a concern in Congress that, gee, this is a nutritional problem, this is America, we shouldn't be having people who have nutritional deficiencies. So they authorized some surveys, and it started out more as nutritional surveys. And so it was through some of that information that corrections could be made, and supplementation to foods, for example, with some of the micronutrients was begun. But the NHANES as we know it now began in '71. In 1999, it was decided to make it a continuous or an ongoing survey. So they're out there every year surveying participants in the NHANES. Data is released in 2-year cycles, and the reason for that is it takes 2 years to get through enough people in the right locations for it to be representative of the U.S. population. So they release their data in 2-year cycles. So I'll refer to a survey period or a survey cycle. And it's really important that the data is analyzed in these 2-year cycles in order for it to be representative of the U.S. population. Now, the design is very complex, and they have demographers, and they have statisticians, and all kinds of people at NCHS, which is the center that runs NHANES at CDC, who are designing this. And it is a stratified, multi-state, national probability sample. So what you have is a sample of people but they are representative of others in the population. And I have been told that for every participant in the survey, they represent something between 40 and 60,000 people in the population. So, but it's the only, and so there are sampling weights. So let me tell you, analyzing these data are not simple, but it is a little different. You have a sample, but there's a sampling weight because that person represents, you know, a lot of people in the population potentially. Every 2 years, they have about 10,000 participants in the survey, and they are selected based on where they live. This is geographically and census tract based. They go to 30 locations in 2 years. It's really quite a remarkable survey. They have a variety of methods. They go to the home, they have a fairly lengthy interview, then they bring them into a mobile exam center, which I'll show you the next, in which they gather a lot of detailed dietary lifestyle behavior. They do computer assisted for the more sensitive questions. They have computer assisted questionnaires, and they go over medical history. It's self-reported. There are no medical records in this. And they're limited in how much they can ask. So they'd probably like to ask more, but as it is, it's an all-day event for someone to be a participant. And then there's some follow-up dietary and nutrition surveys that they can take. They also do a physical examination, which is very thorough. And it is from this physical examination, height, weight, blood pressure, all these basics, that is where all of our national norms come from. The growth charts used in pediatrics, the plot infant weight, birth, you know, whether you're on percentile or not, male, female, those all come from this survey. And then, of course, biological samples are collected, and that's where national norms for lipids, cholesterol, you know, you name it, come from. But there are nutritional biomarkers, which are used to obviously assess the nutritional status of the population. And then we get environmental samples. Now, I call these mobile examination centers the genius of NHANES, and it is in fact what makes it possible for them to collect urine and blood samples for environmental measurements, because as I mentioned, we're measuring very, very small amounts in most cases for these samples that we get. The concentrations are very low. And when you're measuring very low concentrations of, let's say, PBDEs, the brominated diphenyl ethers, you're measuring the actual chemical. Well, the problem is the chemical's all around you. It's in dust, it's, you know. So how do you prevent what's outside the person getting into the sample? And it's very tricky for some of these. Well, this is how it's done. They have we provide pre-screened materials. They are very well trained and experienced at collecting samples in such a manner that it's very consistent. They package them. They do a great job in sample collection. You wouldn't be able to do this with a host of inexperienced individuals or untrained. But these NHANES folks, there are two of these trucks that are going around, two of these sets of trucks that are going around the country in the 2 year, at any one time. 48 weeks out of the year they're traveling, and then they plunk down and they do the survey in that area and bring participants in, and they do all of the exams. They do everything in this mobile exam center. But what is so remarkable for us is that we can get really, really high quality samples that are handled properly, shipped quickly, and so we can measure a lot of these chemicals that we would otherwise be unable to measure, or at least not be confident that we had clean samples. So we don't, now who gets sampled? I'm talking about the environmental analytes. Not all chemicals get measured in everybody, with a couple of exceptions. Everyone over the age of 1 who's willing to have blood drawn gets a blood metal panel. So this is where the blood lead data in the US population comes from. And I'm thinking there's probably in a 2-year cycle between 8,000 and 9,000 individuals who have blood samples, because that's about the sample size in our blood lead tables. The cadmium and mercury are also, because because all 3 metals are measured in the same sample at the same time, we are able to measure all 3. So we have data starting at age 1 for this. Serum cotinine is measured in everyone ages 3 and up. And that's where the pediatric kind of ends. Urine is collected starting at age 6, so we're kind of limited by practicality. Most of the urine chemicals are measured in a 1/3 subset of the participants. Typically, that's about 2,500 individuals. But the subsamples are actually determined to be representative of the population. So those aren't random subsamples. They're actually pre-designed to be representative of the population. So with all of these chemicals that we measure, and actually, I think our latest release of the report on human exposure to environmental chemicals has 250 chemicals that we've measured. And that counts congeners. This isn't all independently separate. You know, I'm counting each PCB congener, for example, as one chemical. So this is what it looks like. This was the 9th report, which was released in 2009, and we do periodic updates to these data tables here over on the right. And what I thought blood mercury might be interesting to show you. This is the layout of the table. Basically, we have the demographic groups running down this side on the left, so you can see how we've been able to break down the data. I'm pulling everything over here. Step around it and get it later. So here we have our groups. These are the survey cycles. As I told you, they're 2 years, each one. And this is the what we do is we calculate a geometric mean, and then we show some of the higher percentiles. And this is where you can tell what the number of individuals in a sample. Now remember, this has actually been weighted, used the sample weights to make those estimates. So you don't have just that number of individuals comprising these estimates. So these are reference ranges. So if somebody comes to you and says, I had blood mercury done, and it's typically organic mercury, you can say, is it high, low, what does it mean? And researchers find this to be very useful because if they're studying a population, they want to know if that population is exposed more than another. There's at least in the US, we have some population-based reference values. So this can be one useful, I think, resource for you to take a look at. Should somebody come to you with some values for some environmental chemicals and you're wondering, is this high or low? You say, oh, well, they're below the median. I guess that doesn't mean they have any unusual exposure, at least as far as we can tell for that particular chemical. So that is kind of what the use of it is. Goals of the national report, as I mentioned, we have used these as a tool to sort of say in the population who's exposed to what chemicals and to what extent. We don't measure absolutely everything out there. Some of the newer chemicals that we measure, we try to stay current with new chemicals that are being put into production, but obviously with the number of chemicals that are out commercially out there, we can't measure them all. As I mentioned, we use these as reference ranges, and they're broken down by demographic groups. We can look at trends in these reference values over time, and blood lab's a good example, and I'll show you a little bit about that later. And it is also helpful to researchers who want to set priorities on linking exposures to health outcomes. So now I'm going to give you just a few examples out of the exposure report with national data and talk a little bit about the chemical and then show you a little bit about how the data have been used to examine differences in different subgroups in the population. So benzophenone 3 you're all familiar with. It's one of the sunscreen agents. It's one of several. It's not the only one out there. But it's the one we tried to look at measuring some of the other ones, but like avobenzone and some of the others, but we had a little challenge with modifying the assay to measure all of them. But it's widely used in sunscreen, as a sunscreen in sunscreen products and in cosmetics. It isn't really well absorbed through the skin, but about 10% or a little less than 10% of the dose can be absorbed. It doesn't stick around. It's what we call a non-persistent chemical. It's pretty much eliminated in the urine within hours, certainly to days. In animal studies, there have been some inconsistent studies of evidence of male reproductive toxicity in rodents, but that's with pretty high and chronic doses. And we don't have any carcinogenicity ratings from some of the organizations that typically rate, like the IARC and National Toxicology Programs, who are in the business of evaluating the data on carcinogenicity, but these just haven't kind of made it to that level of investigation. So from the first time we measured these was in 2003, 2004, and what we found is that regardless of age, the geometric mean concentrations are higher in women. And guess what? They're higher in non-Hispanic whites. Now, does that surprise you? If you think about it. I mean, it's good to have confirmation of what you would expect, right? Fair-skinned people tend to put on sunscreen. Women probably use more products that have sunscreen. Ergo, this is what you see. And actually, it is kind of reassuring to see that this is the case. It validates what you expect. So that was not really any big surprise. But this is one of the uses that we find these data can help us to evaluate. Parabens. Now we measure 4 parabens, and they are really widely used as preservatives, as antimicrobials. They've been added to soaps, lotions, shampoos. They're even in some foods to prevent spoilage of baked goods. They're used in pharmaceutical drugs. And these are chemicals that are very small chemicals. They're rapidly metabolized by hydrolysis and then conjugation. They really don't stick around at all. They're very rapidly eliminated. There are concerns that they might have some endocrine disruptors, some estrogenic types of properties. It would be very weak, I suspect, but there have been concerns about that. There really is no evidence of reproductive toxicity or teratogenicity. And as I mentioned, that their estrogenic activity is extraordinarily weak relative to estradiol, which is sort of I guess, the gold standard. So these have also been measured, and these are urinary concentrations. And perhaps no surprise again, geometric mean concentrations are higher in women than men, regardless of age. And 95% the 95th percentile tends to include more women than men. And more non-Hispanic blacks than non-Hispanic whites. So there may be some racial ethnicity differences, probably driven by products that contain these chemicals. And it may be that there are some products preferred by African American women that tend to have these, whereas it's not the case in some of the products that are used by non-Hispanic white women. So, as you can see, young children have lower levels. Makes perfect sense. Especially if a lot of the products that are personal care products are used by older individuals are the ones who are using them. And this kind of, again, this kind of validates what you would expect, I think. But at the same time, it's good to have the data. So you're not just assuming. Now, this is kind of my behavioral lifestyle, if you will, example. And secondhand smoke comes both from the burning cigarette, the side string smoke, as well as the smoke that's inhaled, just to make sure we're talking, you know what I'm talking about when I refer to secondhand smoke. It's a mixture. It's a tremendous chemical mixture with at least 250 toxic chemicals, 69 of which are known human carcinogens. Several of these are listed up here. Don't need to go through them again. There's been a tremendous body of research, and I know you've all heard the variety of health effects that have been associated with secondhand smoke exposure. They're listed here, starting with sort of prematurity to as the children and then adults and so forth. So one of the things CDC has spent a great deal of effort is developing and validating a method to measure exposure to secondhand smoke, and that validated measure is serum cotinine. So people may say, why serum cotinine? When it's nicotine that's being inhaled. Well, cotinine is actually a metabolite of nicotine. It's a human metabolite, so if you measure cotinine, you know you're measuring what was metabolized in a person. There were efforts to measure hair nicotine, serum nicotine, but again, you get into the problem of contamination, external contamination from other sources that have nothing to do with what's in the person. So those were not as good, but serum cotinine is a very well validated measure of exposure, and in fact, studies have shown that a serum cotinine concentration of 10 nanograms per mil, keep 10 in your mind, pretty much separates people who smoke from people who are non-smokers and are exposed to secondhand smoke. So people who have levels above 10, more likely than not, are active smokers or users of tobacco products. People with levels below 10 tend to be either tend to be non-smokers with exposure to secondhand smoke. And there's a dose relationship between the serum cotinine values between 0 and 10 and the amount of secondhand smoke exposure. So it's really a great measure of exposure. So one of the things that is of concern is the fact that children have pretty extensive secondhand smoke exposure. And as this slide shows you, these are older data, but it's still, the relationships still hold. Young children in 3 to 11 years old have tended to have higher exposure as measured by mean serum cotinine than 12 to 19 in adults. Now, although the good news is that over time, since 88 to 91, there's been a 68% drop in the exposure, in the median cotinine level, indicating a reduction in exposure to secondhand smoke in the 3 to 11-year-olds. And the exposures have been reduced over time. But nonetheless, 3 to 11-year-old children still bear the brunt of a fairly substantial exposure to secondhand smoke, which is a little distressing. So what I would say is that as clinicians, don't give up. I know it's frustrating to counsel about smoking cessation, but you have women who are pregnant at a perfect time to hear a message about staying healthy, both themselves and their children. So don't ever think it's a wasted effort, because most people who quit smoking, when they think back, they say, oh, it's because my doctor really told me. Now, that may not work right away, but keep it up. Don't give up. So that's my sort of plea to you all in clinical OBGYN. So the other thing I thought would be interesting for you to know, I reviewed a paper recently that used NHANES 2001 to 2006, which is more recent data, and it was really distressing to me. 43% of women in the 15 to 39-year-old age group had evidence of secondhand smoke exposure, as evidenced by a detectable serum cotinine level. 43%. That's a lot when you think how smoking has been reduced overall. Pregnant women in that same age group there were 37% of those women with evidence of secondhand smoke exposure, which says to me that there's still, despite all of the successes in getting smoking rates down, at getting policies and regulations to remove smoke from workplaces and from public places, there's still a large percentage of the population exposed to secondhand smoke. So that was simply, I thought that was a real interesting and pertinent to this group. The other, I thought interesting piece of information with regard to secondhand smoke. As you can see, over time, the percentage of children 3 to 19 years old exposed to secondhand smoke and segregated by asthma status. Interestingly, the blue line here that drops, there was a significant decline over time in the number of children who don't have asthma and with exposure to secondhand smoke. But there was no change. So what it says to me, it suggests to me that the kids with asthma are continuing to be exposed to secondhand smoke, which suggests that, well, it may be the secondhand smoke exposure that is contributing to the asthma, and we know that it does. So we have work to do with regard to that as well. Blood lead you're familiar with. You've heard all about the health effects. I'm not going to go through it, except I thought this was a pretty slide. I figured you'd probably hear about lead. But blood lead concentrations, actually, the one thing about blood lead, we have 150 years or so of data that have helped us benchmark blood concentrations to health effects and to risk for health effects, which is unusual for an environmental contaminant, and don't we wish we had this kind of information for lots more? Well, I know everyone's working on it, but what I want to tell you, this almost, I don't know, maybe it's an aside, but this is such an interesting story. I really wanted to share it with you. So in the early 1970s, the EPA mandated that leaded gasoline was going to be phased out. So here on the left, you see the tons of lead used in gasoline, and you can see from 1976 to 1980 levels decline. The amount of lead used in gasoline declined. Now, around 1975, the catalytic converter was introduced. And as I understand it, the unleaded gasolines that were available were very damaging and shortened the lifespan of catalytic converters, which were introduced, of course, to reduce a lot of the particulates and the other components of air pollution. So there were concerns that, gee, we're really kind of destroying our catalytic converters, and maybe this, what's really, how important is it for us to get lead out of gasoline? So EPA used some of their risk assessment folks did some mathematical modeling and used some assumptions about if you have, it's way beyond me, I don't do any of that kind of stuff. I'm sure you understand this better than I do. Or not, yeah. But basically what they came up with was that, well, given the decrease in the amount of lead used in gasoline, it probably accounts for, a couple of micrograms per deciliter drop in the blood lead in the U.S. population. Good estimate. Well, it also turned out that N. Haynes had been measuring blood lead concentrations, and what they did was to overlay the blood lead, and this is in the U.S. population, this is not children. They overlaid it with the drop in lead use in gasoline. And when EPA saw the actual line, they said, whoa, wait. And they were actually on the verge of rescinding or modifying their mandate for reduction of lead use in gasoline, and they completely reversed position and said, oh no, we're going to get it out sooner rather than later.
Shows you some of the shortcomings in modeling, doesn't it?
It does show shortcomings. As I've always said, having data is always better than not having data, and that's why I am the world skeptic about some of that stuff, but that's the way it is. So after N. Haynes 2, EPA further restricted leaded gasoline. It virtually disappeared from gasoline in succeeding years, and let me see here. And this is what happened. The dotted line shows you what happened with the population blood lead concentration. So there was reference today to the CDC statement. Actually, it's the advisory committee to CDC's lead poisoning prevention program. Back in October, recommended that CDC quit using the terminology of level of concern with regard to blood lead, and instead use a reference level. To be honest with you, most of the rest of the world for environmental contaminants uses reference levels, and most of them use the 95th percentile, but because clinically 97.5 percentile is a common reference, upper limit to a reference value is a common reference value. That was what was recommended. And what they recommended was that CDC take two most recent N. Haynes cycles and calculate the 97.5 percentile for 1 to 5-year-olds and use that. And in fact, that value turns out to be 4 point something. So they rounded it up to 5. And that is why the reference value, the correct way to refer to it is not acceptable, but anything above 5 is considered an elevated blood lead level because the reference value is 5. Just if you want to show off for some of your friends and want to correct them. Furthermore, it'll be interesting to see what happens in the coming years. Now, I mentioned to you earlier that when you get down to measuring very low levels of these environmental contaminants, you can really run into problems if your methodology, you're kind of hitting the limit of detection with your methodology. And that's kind of what's happened with clinical laboratories that measure blood lead. Most of them have, I believe, a detection a limit of detection around 2 or 3. And often have a variability of +2 or -2. So I think the PSUs have had the experience of parents coming in and saying, my child's blood lead was 5, now it's 7. It's going up. It isn't changing. But that's one of the sort of details that it's really important to understand, particularly in the current situation where we're very concerned about very low levels. And in fact, I don't even know if the field instrument, does the lead care instrument measure below 10, or does it just provide a reading of less than 10?
I think it's just less than 10.
Yeah, see, there's not precision in these very widely available field instruments, and ones that frequently the WIC clinics and a lot of doctors' offices were using where they were measuring blood leads. It can't measure down to these levels. So this has created a little bit of of a challenge, I think, from a laboratory standpoint. Now, CDC, the method that we use at CDC in the lab, we have a detection limit of 0.25. So, you know, that you can't, it's really hard. We can measure these low levels, but the routine send-out lab and certainly routine clinical lab cannot do that. Mercury. So, where does it come from? Coal-burning industrial discharges and some naturally occurring. Actually, in the oceans, a lot of fish have high mercury levels, not from necessarily from pollution, but from some naturally occurring sources. The problem with mercury, though, when it's in the water, the bacteria can convert it to an organic form of mercury, methylmercury, which then bioaccumulates up the food chain. About 90% of blood mercury is in the form of organic mercury. So when we measure total blood mercury, the table I showed you, that's basically methylmercury. Most of it's methylmercury. Now, the concern is for women who have elevated blood mercury levels and then have a child, because it does cross the placenta, and there is some equilibration. So if a mother has a high mercury level, then the child will too. And there was reference made to the Minamata disaster. There was an epidemic of seed grain contamination in Iraq back in the early 70s. These were terrible disasters, and adults were horribly affected and died. And children born to the mothers, who some were not even symptomatic, but those who were horribly affected. And you saw the picture today from the Minamata Bay disaster, and that was an industrial pollution problem. But in our society, I'm happy to say we don't have that kind of a problem, but we do have concerns because methylmercury is really not, it's not an essential nutrient, shall we say. But the concern, there have been some cohort studies done, and some data was available to do really some estimation of, so what's the most sensitive effect that is seen at these lower levels of mercury, and at what kind of a blood level in cord blood, because that's kind of the gold standard, not that it's measured there, but that's okay. You kind of just, it is really in cord blood. What's the lowest level, what would be the sort of most sensitive effect and the lowest level at which it might occur? So the approach that was used, the National Research Council commissioned a risk assessment using the data from the Faroe Islands, if you're familiar with it, because that was the cohort in which some effects of methylmercury were seen. The most sensitive effect was found in a test called the Boston naming test. I frankly don't know what it is, but it's one of the many scale. Is it a scale within
It's
the?
one of the it's one of the subsets of a neurocognitive test.
Right, and it's a validated test, so it should be a good indicator of effect. So what they found was that 5% of the children were at risk of having an abnormal score on this test if the cord bloods had blood values were 85 micrograms per liter. And the confidence interval around that estimate was 58 to 112. So what the NRC felt was that the most sensitive effect was Boston naming test, and just to be conservative, let's use the lower confidence interval, which is at 58. So that's one approach. EPA used some different methods. They kind of start from the other end of how much fish can you eat and have a blood level. Yes, so they have a different way of going about it. And they came up with 5.8. So I don't know, somewhere between 5.8 and 58. Frankly, I've looked at the data in the US population. There are no women in the US population and Haines that we've looked at who have values above about 15 or 20, maybe 20. In fact, I'm not sure they were women. But I'm happy to say that in the US population, people don't get anywhere near 58 unless there's some unusual exposure. Obviously, you always have to account for unusual situations. But in the general population, it just really is not something that we observe. But nonetheless, it's probably good to avoid it if you can. Does that mean you shouldn't eat fish? I don't think so, personally. Now, another question my OBGYN colleague said, well, what about fish oils? So I looked up on that, and actually there's been very little research, but there have been a couple studies, and they really found no detectable methylmercury in fish oil. So, you know, if somebody is interested in using fish oils, they're probably not going to be contaminated with with methylmercury, so that's probably a safe recommendation if someone's really leery of eating fish. However, just for your information, since sometimes these global advisories come out, avoid eating fish that are high in methylmercury. You go, well, what's that? Okay, so I looked it up. There's 4 species. There's 4 fish that you could keep in mind if you would like. Tilefish. And I like this particularly because this is in the Bureau of Fisheries. These are all saltwater fish, and we're talking pretty much saltwater. So tilefish, and there's a whole slew of different kinds of tilefish. They can be higher because they're up in the food chain, so they're eating the smaller fish, and just like king mackerel, swordfish, and shark. So those are the 4 types of fish that can have higher concentrations.
They have long lives too.
And they have, and they're big. Right. They're huge fish. They're huge fish. So that's just a little bit of maybe some practical information for you. So here's a little more just to kind of temper the, give you a little more detail about blood mercury in women in the U.S. population. A few years ago, we looked at several cycles of data and said, gee, is it, people sort of think they kind of lump 16 to 49-year-old women into the same category of risk for having a child with elevated mercury. Well, think about it. Mercury is one of those chemicals that accumulates. So the longer you live and the more fish you eat, the more likely you will have a higher level. And indeed, what we found, you can see the adjusted geometric mean, and these are adjusted for demographic factors largely, that the younger the woman, the more likely she is to have a lower blood mercury. Good. She's more likely to get pregnant and have a child, right? Not always, but in general. So women through the earlier part of the reproductive years tend to have lower blood mercury levels, whereas the older they get, the more likely to have a higher blood mercury. I still would point out that these are still pretty low levels. Now, one thing I can't find anyone who can explain, and I would love to know why, but non-Hispanic blacks at all age groups, and in men as well as women, have higher blood mercury levels. And I can tell you it's not from eating fish. It is not from eating fish. And I don't know if it's there's some hemoglobin, there's some racial ethnic difference such that non-Hispanic blacks have higher blood mercury. So I'll leave you to ponder that. But at least the good news is that the younger the woman, the more likely she is to have a lower blood mercury level to start with. Another, shall we say, element, it's a metalloid, that you probably have heard about, and you might get asked about, so I thought I'd cover it here, is arsenic. There are both natural and anthropogenic sources, mining and smelting. They have a lot of problems, actually, out west around some of the mining sites and the old smelter sites with arsenic contamination in the soil. There are 2 forms. Just to be simplistic, there's an inorganic and organic. And the concern is largely around the inorganic form of arsenic. And it is generally this form which is present in drinking water, and there are concerns about it being present in food, specifically rice and fish. Organic arsenic, on the other hand, largely comes from seafood and is considered non-toxic. It really kind of passes right through. Both of these forms are well absorbed when ingested in water or food, and they fairly rapidly get eliminated in the urine, principally in the urine. Because of the concerns about specifically inorganic arsenic, but arsenic in drinking water, there is a drinking water standard in the U.S., and it's 10 micrograms per liter, which is the same as 10 parts per billion. You may have heard that in some of the press around arsenic concerns in apple juice and rice in the recent last year or 2. Urinary arsenic is therefore used to evaluate exposures, and their recent exposure. This is not a chronic accumulating kind of a toxin. It acts fairly quickly. It passes through the body. And so urinary arsenic is a great way to measure exposure. Now, most laboratories, if you send off a urine sample and say, I want to know the urinary arsenic, they're going to measure total arsenic. And that means they're measuring a combination of the inorganic and the organic. Well, frankly, you don't care about the organic form because that's not really the source of toxicity if you're concerned about toxicity. And if they ate shellfish or seafood last night, they're going to have a high urinary arsenic. So bear in mind. That's why at CEC we have taken to speciating arsenic, so we can actually look at different inorganic and organic arsenic species. But the goal of that, of course, is to sort of segregate the toxic from non-toxic species. So as I mentioned, there have been some concerns recently that have come up because of concerns about arsenic in apple juice and arsenic in rice. And the reason for this concern, of course, is because arsenic, among other things, is a carcinogen, but it does have some distinct health effects. So, y'all remember that the issues of the arsenic in apple juice, arsenic in rice? Is that ringing a bell? No, you guys were on call. You didn't.
You didn't watch Dr. Oz.
You didn't watch Dr. Oz. Okay, so there was actually an independent group, I think Consumer Union, that did some measurements, and they took some samples of arsenic juice, and then later did some samples of rice, and they found some of them had elevated amounts of arsenic. And in fact, the concern on the apple juice was, oh my goodness, these samples have more than 10 parts per million, or parts per billion, which is the drinking water standard. Well, the drinking water standard is based on the assumption that a person drinks 2 liters of water a day. Now, anybody who's drinking 2 liters of orange juice a day or giving that to their kid needs to have their head examined, and their teeth are going to fall out. So, you would think.
Yeah, you're true.
Anyway, so this, which is why the FDA, which actually is responsible for regulations on foods and contaminants in foods, had really not wanted to set a standard to enforce with arsenic. They do periodic testing, not a lot of samples, but they've been doing periodic testing and had really not found really high levels. And in fact, these original samples that were, I think, analyzed, they just measured total arsenic. They didn't actually separate them. So, as it turned out, the FDA did do a larger analysis of both apple juice and rice. They did not find really high levels or alarming levels in either. And I've actually given you the links on this so that if you want to go see what FDA did and what they recommended, their advice actually, I know the AAP was, I think they approached AAP for sort of some consensus on eating a balanced diet, eating a variety of grains when it comes to rice. You shouldn't feed your kid just rice cereal ad nauseum. And it's possible to reduce the arsenic in rice if you really rinse it with large volumes of water if you're cooking it. However, you can also reduce the nutritional value. But for people who have a lot of concern, that is a technique they can follow. The same went for the apple juice, but at this point they are considering an action level of 10 parts per billion simply because they did find a few of the samples that had levels that were a little higher. But their overall conclusion was that apple juice is safe. And that was good. Briefly, I thought this would be an interesting one to show you. Okay, yeah, that sounds about right. In the U.S. population, I've just shown you women and children's urinary arsenic concentrations, and they're around 6, 7, 8 micrograms per liter. Now, there are places in the world that have horrible problems with arsenic contamination of drinking water, and it's natural contamination. The areas of Bangladesh, northern India, that whole area, there are millions of people who are poisoned by arsenic, and people who develop skin lesions, liver disease, neuropathy, and ultimately cancer from the very high levels of arsenic in the drinking water. These are very rural, undeveloped areas. They use tube wells, which are fairly shallow and don't get through the arsenic contamination before they're pulling the water out. So what I showed you here, just so you realize that this can be a serious problem, there were a small number of 6 to 11-year-old children who actually had evidence of arsenic-induced disease. They were drinking from a well that had 750 micrograms per liter. Remember, our drinking water standard is 10. Their average, the mean urinary arsenic concentration in their urine samples was 1,350 micrograms per liter. And in another group of children and adults, a small group, also showing evidence of arsenic poisoning, they have levels close to 800 micrograms per liter. So this is a serious public health problem, global health problem, and I don't think anyone's come up with a great solution.
There's one guy who won an award a couple of years ago, an engineer, who developed a low-cost method of some kind of an exchange system.
Removing the arsenic, that's
So,
right. That's what it's going to take.
Yeah, so you can take some clay pots and some soil and a few other things and pour the water through.
and try to remove some of the arsenic. But that, just to let you know, there are places in the world that have horrible problems. Briefly, very briefly, the National Children's Study is a federally mandated study, which is to be a long-term prospective cohort study following children from birth to age 21, and to evaluate exposures, environmental exposures, broadly defined environmental, not just what we think of environmental chemicals, on child health and human development. CDC proposed to them to do a pilot study in their feasibility phase, and what this amounted to is that the 7 centers that started recruiting early in 2009, we got urine samples and blood samples, 3rd trimester maternal samples, and the goal was to get cord blood, but there were some technical issues, so we have some urine from 6-month-old kids. We measured about 120 chemicals in those samples. The goal was, NHANES does not capture many pregnant women, and they don't catch the young infants. So we were hoping that, one, we could help them in their design, but we could also at least add to the biomonitoring database for these 2 populations that are underrepresented in every other population-based survey. This is just a little bit of what we found. The concentrations of these 3 environmental phenols, this benzophenone 3, which is the sunscreen agent, bisphenol A, and triclosan. Bottom line is these concentrations in pregnant women, there are about 500 of them, their urinary concentrations were very similar to what is seen in similar-aged women who aren't necessarily pregnant. So what it says to me is that pregnancy does not confer an unusual exposure to these agents. We have a whole bunch more of these to analyze and put together and figure out how they compare to some of the NHANES data, but we're using NHANES, not pregnant women, but similar-aged women as our comparison group. So this is kind of where we are with that. Final thoughts. NHANES is very good for providing ongoing data on the U.S. population's exposure to environmental chemicals. We get reference values, which are really important and have much use. It has limitations. It's cross-sectional, which means they get measured one time. Every cycle is different people. It has national estimates only. You can't break it down by geographic region. You can't do it by season, and you can't do it by by location at all, because this is to protect confidentiality of the participants. If there are many in a given location. It doesn't have good data on specific population groups and subgroups, as you can see. It doesn't talk. We don't have information on where these people are getting exposed or to what, other than what we can get out of their dietary information. And as I mentioned, there's very little data on children under the age of 6 and on pregnant women. So hopefully the NCS will come through and will at least be a source of serial biomonitoring information on this population for whom we have very little information, pregnant women and young children. But separate studies will have to be done to determine if there are relationships between exposures and health effects, and are certain levels safe and which levels are not, which are associated with disease, which are not. So that concludes.
Thank you very much. Any questions for Dr. Mortensen?
How long has the National Children's Study been going on?
It's been planning, the Children's Act of 2000 is what actually mandated it. There have been political and all kinds of problems. It goes on a year-to-year appropriation. There are certain administrations that have not wanted to fund it. It's been really difficult. There's been a lot of turnover at NIH in terms of leadership. I think NIH was ambivalent. They didn't really feel like this was something they wanted. It didn't really fit with their model, really. But they were tasked with National Institute of Child Health and Human Development was actually tasked with doing it. So it's been a really difficult, challenging undertaking, and they're still trying to figure out how can they do a representative sample and stay within budget. I mean, there's a lot of practical challenges.
What year did the Vanguard Center start enrolling?
2009.
So that's when the data.
The Vanguard, the best data to date, actually own data, it's really the Vanguard sets. What they did is they had 7 sets, the 7 sites that were earliest under contract and were best, moving along. They had protocols, and they had a very defined, their recruitment was a great idea, but totally impractical. Go door to door in the geographic area where they were trying to recruit, not do a census, find the pregnant women. Well, it was much harder to find, and there weren't as many pregnant women found that way as they had hoped, and it was just cost prohibitive. But the 7 centers did that, and they had enrolled about 2,000 kids, I think, among the 7 centers. The beauty of that Vanguard study, from my standpoint, is that they are geographically dispersed. They have definitely racial, ethnic differences among the centers, because one of them is Utah and one of them is Queens, New York, so you can imagine how different those are. And they also have some economic ranges in them that sometimes you don't find, but they are kind of clustered, so there's a little bit of that. But it's a fairly diverse, but it's not representative. It's really a convenient sample. So,
Cool.
and they are still actually continuing to follow the kids, but
The protocols change so much though.
yeah, the protocols are really a moving target. Those protocols they started with were well established and set, and then they kind of started trying to figure out other ways to do things, and things got really very fluid.